apologize for the delay, but his talk is again equally interesting talk in this era, and it's titled Fast Track Knee Arthroplasty.
Right. Thank you, Jay, for this interesting talk, because I have to get vaccinated soon, so it was good to hear. However, I saw you have a slight cold, so I hope this is not the effect of the vaccine, but we will see what happens afterwards. So going to a more boring topic, sorry guys, I will have to explain during a few minutes the concept of fast-track knee arthroplasty, but it seems to be very interesting during the COVID period to get our patients out as soon as we can in safety. So if we talk about fast track, we have to discuss this rather as enhanced recovery. And enhanced recovery shows you basically if a patient has a certain functional level and they go through surgery, this surgical shock will have some impact on their entire organism, and especially on muscle function and inflammatory responses and everything that happens. And you will see that it takes a long while for them to go back to the same level. If you want to have enhanced recovery, you try to get them at a higher stage by the pre-op work. Then you try to reduce the deficit that is created by the surgical shock by the perioperative and postoperative. And as you see, enhanced recovery makes sure that they are doing better after than before. And that is the entire concept that was developed by my good friend Henrik Kellett, with who we have done some work in the last 7 to 8 years. And already in 2013, we wrote a paper together about fast-track knee arthroplasty stages and future challenges. And as you can see, we listed at that time all the things you had to consider when you were looking at fast-track surgery. And today I would extend that to the one-day arthroplasty. So basically, in a nutshell, doing fast-track surgery means you have education and patient preparation. Remember, you have to get them at a higher level than they are. Then you do the peri-op multi-modal management, and then you have to get rid of some of your non-evidence-based habits. These are the things you have been seen from your professor. No real randomized control trials, but only transition from one surgeon to the other surgeon. And maybe you have to try to get rid of those if you can see and trust other people that are doing well. Now, when you talk about patient information, I think this is really important. You have to make your patient the partner for success, and that works by reducing anxiety because of the unknown. What we often forget as surgeons is that we do this a few hundred times a year, but patients only go through this once or twice if they are lucky. And that is why you need to inform them how this will be and try to understand that for them this is an important event. I also ask them also to always to bring a coach so that there are 4 ears that can listen to what the information nurse is telling them so that they remember and they can have some feedback. Pain management, I will quickly go through it later on, but it has to be multimodal, and we are still all looking for the secret. I don't think a really painless, completely painless surgery will ever exist. This would be really strange that your brain and your body would accept that you went through a procedure with major tissue damage and that you would never have noticed it. It would be a strange event. Optimizing transfusion strategy is a great point. You have to try to go to 0 transfusion. I think today with all we know about bleeding in knee arthroplasty and the adjuvant drugs we can use to reduce it, you really have to aim for zero transfusion, and you cannot accept that this will be the old 30 or 35%. Rehab is also a very well-known tradition. There is very low evidence, no high-quality randomized studies, only a few out, and it comes with a high ambulatory cost. Today, of course, many companies or startups are jumping on the electronic way, but we will still have to see what this is giving. Of course, the reduction of DVT, so the duration of thromboprophylaxis, has been going down in the last 10 years, and aspirin has become much more popular. So when you arrive at Copenhagen airport, and that is where Henrik Kellett lives, you can see this way, fast exit. And as Henrik Kellett has always been saying, fast-track arthroplasty is not about getting your patient out as quick as possible. It's about getting there in a safe way, and that you can reach by doing the things right, by doing the right things, and by doing the right things right. And that is the difficult part, and that is why it's an evolution, and why it's difficult to go visit someone, see what they do, copy it, and believe that when you come home, it will work. Now, let's go quickly through pain management. I think that you need, as orthopedic surgeons, we had a fantastic talk about COVID. I think we also have to know now a little bit about pain and patients that have preoperative predictive factors. I don't think you still have to say this is an issue for my anesthesiologist and then afterwards complain that it's not working, because you are seeing the patient pre-op. If they would come back to you and say, I don't think you should operate this patient because she has too many risk factors for surgery, you would get upset. And if they have pain afterwards, you will probably believe as an orthopedic surgeon that it's because you cut your tibia at 0 degree and not at 3 degrees, but still just try to remember this. The risk factors for severe acute pain, so immediately after total knee, are younger age. Why younger age? Because the nerves are much more active. Female gender, and this is not a sexist remark, this is just observation in studies, and it's not a hormonal thing, it's a multi-factorial thing, and you just need to remember this. Psychosocial factors, especially anxiety, level of pre-op pain, patients who have very high levels of pain, and especially if you see on the x-ray that this is very limited disease, please be careful. And then, of course, incision size and type of surgery. It's not difficult for you to understand that someone who will be going through a medial uni will probably have less pain than if you are doing a massive revision with cones, as we saw earlier today by Ashok. For the chronic pain, we are lucky. You see that many of those factors come back: younger age, female gender, anxiety, catastrophizing depression. Of course, there is a factor of genetics, which will always be difficult to determine. Pro-inflammatory conditions. So, for example, patients who are very obese, they have a pro-inflammatory condition and they will have more inflammation. So these are important factors that you should remember as a surgeon, and then think about it and link it to the type of pathology that you see. So here we see how the multimodal works. You see the tissue, this is the knee, this is the nerve ending going to the spine, and then you have central modulation in the brain. You see here where the different types of the pain drugs work. So you have the anti-inflammatory drugs, which are local. You have local anesthetics. They also work on the peripheral nerve, on the dorsal root of the ganglion, which is arriving in the spine. Here you also have the effect of alpha-2 agonists and opioids. And then in the brain, you have more the opioids and also the paracetamol. We discussed a little bit in earlier talks the effect of local infiltration, analgesia. I again think, like what I said during my alignment talk, I think there is a lot of confusion. We delegate this too much to other people, and then we don't want to understand. I think that the adductor canal blockade is much more easy to perform for a surgeon. If you are doing a subvestus approach, for example, you have easy access to under canal. You can inject this with 1 or 2 doses of local infiltration, and you will have performed an adductor canal blockade without any difficulties. The second thing that I would advise you to consider and think about is that you need to do the local infiltration step by step. This is what you do with preventive and preemptive pain control. And if you do this only at the end of the surgery, all the information of the pain that you have created during your surgical procedure has gone already through the nerve to the dorsal spine and will go up to the brain. So it's a secret to block it from the start. So immediately after incision, I will do this adductor canal blockade. Then I will go step by step. Before I do any cuts on the femur, I will perform this, this femoral blockade with specific points. And if you are interested, we did a video together with Zimmer Biomed on what I call the anatomical knee blockade, the knee block. And you can have a look at that video, and it will show you step by step how you can block the femur, then do your femoral cuts. Here you see how you do the posterior infiltration. You can also infiltrate the zone between the capsule and the nerve. Again, your anesthesiologist has to do a posterior approach, and very difficult. You have done already the posterior approach, and so you are really there where you want to do this IPAC blockade. Then when I'm happy with the femur and the femoral work is done, I do proximal tibial block, and then we will continue with tibial preparation. So as you understand, each time we have done the block before you start cutting the tissues, and this helps you to keep the information from the joint going less through the peripheral nerves to the dorsal root of the spine. Finally, you can add some posterior block, IPAC, as I said, and you can do that with the amount of narrow pin that you have. Transfusion management, as I said, we aim for 0 transfusion. That means you have to check the hemoglobin level pre-op, then use, of course, tranexamic acid, which made a big difference. There is a lot of discussion against orthopedic, orthopedic confusion with people saying you have to use it locally. You can use it, of course, intravenously. I think probably everything works through resorption. And if your anesthesiologist is forbidding you because he's looking at the old literature, not about TXA, but about other similar products that were used in cardiac surgery many years ago, then you use it yourself. You can either infiltrate it together with your local infiltration analgesia, or you just put it in the joint. And I think we have to understand where this confusion comes from. Don't use any drains anymore. It's useless. I know that someone will probably reply that this gives more swelling, but don't forget that the knee is a closed joint, and if you put the knee into flexion, there is almost no dead space, and you will really have not so much bleeding or any swelling. Also, try to have an evidence-based trigger to transfusion. Try to decide what is your trigger point and not just transfuse because someone decided that they wanted to do that. DVT prevention, we think the magic is patient stratification. If you will do your first one-day arthroplasty on a patient who has for 3-generation pulmonary emboli in their family, you will probably get into trouble. I think you have to eliminate potential risk factors, favorize mechanical prevention, and then use aspirin as we are all trying to do and get away from these bleeding drugs like the oral anticoagulants, which are probably over-treating our patients. And we were excellent experiments at the start of that. We had some experience with it. So if patients are still in the hospital, why is this? Well, because your multimodal and local didn't work. You have to try to reduce this surgical stress response. We like the steroids for that. All the reduction of organ dysfunction is done by reducing the use of morphine. Make them early mobilized. This is really a secret to get their organism working and getting back to eating again very quickly. This is a paper that I continue to bring out from Jay, where he showed that on day 2, you have the highest risk of eventually potential complications, the medical complications that we are all afraid of. So our patients usually, if they are in the range where you can expect is the age, they have to stay at least until day 3 in the morning, so that we have done and we have this type of paper to protect us against any issues in front of court. A few years later, I wrote again with Henry Kellett, as you can see, this review paper for the JBGS British, and you can see that we called the day case total knee replacement the fastest fast track, which is in fact the shortest day that you can deliver to your patients. And here you see that despite of all the work you do, so you can do a lot of pre-op work, you can make sure that this works, then you can reduce the perioperative complications. This is how well the surgeon and the anesthesiologist know their stuff and work together. But still there are some things that go out of your control, and that is especially orthostatic intolerance. And so please, in this group, remember the paper of Jay Pervisi. Day 2 should at least be the time that you keep the patient in if you're expecting any comorbidity or potential mortality. So fast track is a mentality, it's a learning process you and your team have to go through. It is a never-ending quest for amelioration. You can never stop, you always have to be interested in the smallest details. You have to know about sutures, how to close a wound. You have to know about the type of bandages that you want to use, because this is everything that will make a difference. And it needs clear leadership, as we all know, and this is the experience you always have in your daily life. People hate change, and so you need to motivate them to accept change. And once the change is there, they will all be happy about the changes you made. But this will always take some time and energy. Thank you.
Thank you, Professor. Excellent talk, which will definitely help most of the orthopedic surgeon here also. Two important changes what I thought